Thank you, Dr. Cleary, and everyone here for attending this presentation of Improving Military Mental Health by Exercising Mindfulness. Approximately 34% of the population suffers from an anxiety disorder at some point in their lives. Between 2021 and 2030, mental health care costs are set to rise from $384 to $560 billion. Even more frightening, there's a projected yearly productivity loss of over $6 trillion by 2030. Anxiety also leads to decreased quality of life and poor health outcomes. But secondary to stigma, many people choose to avoid treatment. This is especially true in a small but vital segment of the population, the military. There's been almost 600,000 new cases of anxiety disorders in the military over the past 20 years. While women comprise only 10% of the armed forces and 18% of military officers, they are one of the most vulnerable populations. Overall, women have a higher incidence in both the civilian and military population of anxiety disorders when compared to men. Veteran studies of females show an increased risk of anxiety, depression, PTSD, and suicidality. Yet many female veterans steer away from mental health studies in the Veterans Affairs Medical Center, secondary to fear of re-triggering PTSD symptoms. There are few studies dedicated to female active duty service members. This may be secondary to their purposeful withholding of their suffering for fear of career retribution. How can we treat symptoms, prevent disruption of operational tempo, improve quality of life, with distrust in the system and limited providers? Science, which led to my PICO question and literature review. In female naval officers that self-report symptoms of anxiety, how does diaphragmatic breath relaxation training and guided imagery, compared to no intervention, lead to decreased anxiety and improved satisfaction with life within a 4-week period? The population I've selected is female naval officers secondary to increased incidence by born gender, perceived stigma against traditional treatment in the military, and potential benefit to the individual and the community. The evidence-based intervention is diaphragmatic breath relaxation and guided imagery training. The outcome hoped for is decreased anxiety and improved satisfaction of life as measured by the Generalized Anxiety Disorder 7 scale and the Satisfaction with Life scale. The time frame is 4 weeks, though the intervention will be taught once with the participant continuing to utilize the self-care interventions on their own for a 4-week period. EBSCO Discovery Service was key in being able to access multiple databases for the literature search, including APA PsycInfo, Academic Search Premier, and CINAHL. 119 searches were being conducted. Keywords for the population included female service members, female veterans, servicewomen, and military officer. For the problem and intervention, life satisfaction, quality of life, well-being, anxiety, GAD-7 screening for anxiety, as well as guided imagery and mindfulness. Breathing exercises, breathing techniques, diaphragmatic breath relaxation, diaphragmatic breathing, or abdominal breathing were also used. Lastly, telehealth or video teleconferencing were words of interest. By successive pairing of keywords and utilizing limiters such as peer-reviewed journals, publication date, and modifiers, 139 articles were left. Through refinement, articles were selected based on their appropriateness of application to the keywords. For the duration of this presentation, I will refer to the diaphragmatic breath relaxation as DBR, guided imagery as GI, video teleconferencing as VTC, and generalized anxiety disorder scale 7 as the GAD-7, with the satisfaction with life scale, the SWLS. As noted in the previous slides, women have an increased incidence and prevalence of anxiety disorders. However, women veterans may avoid going to the VA secondary to re-triggering of symptoms. In a 2021 non-VA hospital study of over 1,700 veterans, only 5% were female. However, using logistic regression, they determined female veterans to have a 27% higher risk of PTSD, a 25% higher risk of depression, a 20% higher incidence of lifetime mental health services, and a 16% higher incidence of suicidal ideation compared to their male counterparts. In a 2021 study by Roche et al. Surveying female military officers, 66% of respondents admitted to actively avoiding seeking mental health care. The literature review serves sufficient to warrant this clinical scholarly project for active duty female naval officers, as it is clear there is a need, but it is unclear that the treatment has been targeted specifically for them and in a manner which they would choose to interact with while serving in the military. Mindfulness-based interventions, or MBI, have been shown to reduce anxiety and depression and improve quality of life. However, the term mindfulness encompasses multiple interventions. Therefore, 2 specific evidence-based practices were sought out to enhance replicability in future studies: diaphragmatic breath relaxation and guided imagery. DBR has been shown to reduce anxiety 28% in adults as reported on the Beck Anxiety Inventory over 8 weeks measured in paired t-test. Serafim et al. Notes deep breathing exercise significantly decreases anxiety in adults by 8% as measured also in paired t-tests. Guided imagery has been shown to be effective in reducing multiple forms of anxiety in veterans, students, and patients. In patients undergoing chemotherapy treatment, anxiety was reduced over approximately a week in paired t-tests. In a randomized controlled study of 60 undergraduate students, GI was shown to reduce anxiety from baseline to follow-up treatment in only 20 minutes of instruction. GI is one of the top 5 mindfulness techniques offered and asked for within veterans populations. However, Farmer et al. Notes only a third of the VA can meet the demand. It is for this reason the mode of intervention was selected via video teleconferencing. Telehealth is the delivery of healthcare through technology. Unlike traditional phone-based telehealth, video teleconferencing, or VTC, provides the ability to communicate anywhere there is access to the internet or cellular network. It has been proven to increase access to care for a variety of reasons, including mobility issues, costs, isolation in a pandemic, or circumventing mental health stigma during in-person care. Lastly, VTC improves the ability to see specialty providers such as psychiatry. The VTC Zoom was chosen as it is a free application which can be downloaded on any mobile device and used on its own interface or on a web browser. A waiting room feature allows for confidentiality. It was instrumental for this intervention because I was able to communicate live in person with participants in Africa, Asia, the United States, and Middle East as if I was in the same room. The purpose of this project was to reduce anxiety and improve satisfaction with life through the MBI of DBR and GI. To evaluate the success of this project, the following question was asked. Does a one-time mindfulness-based intervention taught over VTC reduce anxiety and improve satisfaction with life in female naval officers in 4 weeks? It was hypothesized that in a paired samples t-test measuring anxiety and life satisfaction scores before and after the 2 interventions, female naval officers should exhibit an improvement of approximately 10% on the GAD-7 and SWLS within 4 weeks. Dorothea Orum's Grand Nursing Theory, the theory of self-care deficit, is one which guides the CSP. There are 3 main parts to Orum's self-care theory. The first part of the theory of self-care is when nurse assesses what the individual currently can do to care for themselves. Certain conditions of self-care must be met, known as requisites. When the requisites of self-care can't be met continuously, there is a deficit. There are 5 methods in which nursing can help to rectify a deficit: acting, guiding, supporting, providing, and teaching. It is through these means which the nursing system is activated. The amount of assistance required, fully, partially, or supportive, is dependent on the degree of deficit. Applying the theoretical framework through research of my population, there is a health deviation deficit of anxiety management that is greater in females without the resources to manage symptoms. Teaching the participant and providing an environment over Zoom may be the best means to assist them to resolve their symptoms. Activating the supportive educative nursing system, I taught the participants DBR and GI, providing them with means of self-care to decrease anxiety and improve their satisfaction with life. Dorothea Orum's self-care deficit theory posits that when patients can perform their own self-care, they have better quality of life and outcomes. Therefore, this theory offered a clear guide to this project. An electronic post went out on the Facebook groups Female Navy Officers as well as Navy Nurse Corps, with the flyer seen on your screen soliciting participants to the project. My UMass email address, Google Voice number, and Facebook Messenger were provided to potential participants to ask questions and to sign up for screening prior to the intervention. Each candidate was screened individually to ensure they met inclusion criteria of active duty service and didn't meet exclusion criteria, which included suicidality within the past 12 months, current mental health treatment, current or planned pregnancy in the next 6 months, or upcoming military separation. Participants understood, if accepted in the CSP, their presence was required at the one-time intervention via Zoom, and that should they meet exclusion criteria during the time of intervention or 4-week observation thereafter, they would be disenrolled. A personal Zoom link was established for the private 60-minute intervention. The participant was asked to be in a location free of distraction, as they were located globally and the meetings were held at their convenience in their time zone. At the scheduled time via Zoom, the participant was screened once more for exclusion criteria and administered the GAD-7 and SDLS to obtain baseline measurements as well as ensure understanding of the forum. A script was followed that I offered, which gave a brief overview of the functioning of the pathophysiology of the respiratory system as it relates to the mind and autonomic nervous system. Additionally, the history of breath training and guided imagery with related examples validating its use were provided. The participants were then instructed on DBR with return demonstration. The second intervention, a 5-minute GI exercise of a sunrise, was provided. 2 examples of both techniques were given to further establish positive neural pathways of the exercises. Participants were asked to continue to practice twice a day for 1 minute for the next 4 weeks. They were informed they would receive an email 2 weeks later checking on them, though they could reach out with any questions or concerns at any time. They were also informed at the 4-week conclusion they would be sent the GAD-7 and the SWLS to fill out once more and return by email. They were given an opportunity to ask questions, and then the Zoom link was ended. No recordings took place. Regarding collection of the descriptive statistics, at the time of the intervention, each participant was interviewed via Zoom to ensure they continued to meet inclusion criteria and assigned a CSP identification number. The variables of interest were asked, the GAD-7 and SWLS were administered, and resulting information was recorded in the data collection document viewed on this slide. The document was saved according to the rules and regulations set out by the IRB and to cross-check when entering into SPSS. The information was transferred to SPSS for analysis and paired samples t-tests, measuring anxiety and life satisfaction scores prior to the intervention and at the conclusion. The table on this slide provides an overview of the variables of interest. The sample size for this CSP was 14 participants, and average participant age was 37 with 13 years of military service. Approximately 3/4 of participants were married and 80% of them identified as white. All had at the minimum a bachelor's degree, over half had master's, and 1 had their doctorate. Over half of the participants were lieutenants and all were O3 and above. Almost 1/3 of participants were lieutenant commanders. 1 commander and 1 captain participated in the CSP. The table on this slide reveals that there was a statistically significant difference in the GAD-7 scale for participants that received the intervention. The average difference in the GAD-7 following the intervention was 6 and standard deviation of 4.56. As the t-values for the GAD-7 are greater than 4 standard deviations above the mean and the p-value is less than 0.001, there is less than a 0.001% likelihood the intervention result happened by chance. The table on this slide reveals there was also a similar but statistically significant difference in the SWLS for those who received the intervention. The average difference in the SWLS following the intervention was negative 3.36 and standard deviation of 3.48. As the t-values for the SWLS are greater than 3 standard deviations above the mean and the p-value is less than 0.01, there is less than a 0.01% likelihood the intervention result happened by chance. The purpose of the project was to reduce anxiety and improve satisfaction with life through the MBI of DBR and GI. To evaluate the success of the following project, the question was asked, does a one-time mindfulness-based intervention taught over VTC reduce anxiety and improve satisfaction with life in female and naval officers in 4 weeks? It was hypothesized that in a paired samples t-test measuring anxiety and life satisfaction scores before and after the 2 interventions, female naval officers should exhibit an improvement of approximately 10% on the GAD-7 and SWLS within 4 weeks. The results were statistically significant and correlate with previous studies exhibiting the benefits of decreased anxiety, including meta-analysis of randomized controlled trials. From an average anxiety level of 10, anxiety reduced to 4, a decline of approximately 60%. This is a difference clinically between moderate anxiety and minimal. Furthermore, the satisfaction with life improved from 21 to 25, a 13% improvement and the highest score of slightly satisfied. Statistically, this was significant. Previous studies of MBI find that a decreased anxiety also leads to an increase in satisfaction with life. Clinically, this may be significant for the individual provider and military readiness, as an increase in the SWLS signifies an increase in one's perception of their satisfaction with their life circumstances. This may lead to retention of valuable service members rather than attrition from the armed services, secondary to perceived poor satisfaction of life of an active duty officer. Because of the ability for the APRN to work both technically and academically, they are flexible within the military medical community. They work as leaders in the Pentagon, manage clinics with thousands of beneficiaries. They are executives within directorates and individual providers to thousands of Marines and sailors deployed by air, sea, and land. APRNs are found in active duty, reserve, and civilian forces within the military. They apply their expert knowledge of leadership, disease processes, and treatment with the nursing skills needed by their community. This means that as a leadership, the APRN admiral directing the nurse corps could influence the ability for providers of every level to be trained in DBR and GI, secondary to the outcomes of well-done studies emphasizing its excellence. As the chief nursing officer of the ship, wing, battalion aid station, or hospital, they have the ability to run data to show the effectiveness of MBI in their patient population. As the educator, they may teach the intervention themselves. The ability for the APRN to be present in every facet of the intervention allows for not only individual but global improvement in systems. However, there are some limitations with this project. There was selection bias as it was composed of a convenience sample comprised of the solicitation of female naval officers rather than a random one. Therefore, the first assumption of t-test validity was not met. Confirmation bias may have affected results. I may have taught in an overly persuasive manner. Additionally, I'm a retired female naval officer. Wilson et al. Notes that service members feel better perceived by others with military experience. In a similar though randomized controlled trial of breath therapy sessions and anxiety, therapeutic alliance was considered one of the primary indicators of improvement rather than the breath therapy modality itself. There is limited generalizability. The CSP participants were educated with a bachelor's degree or higher and women. Therefore, it may not be applicable to males or those without undergraduate education. Additionally, secondary to convenience and time commitment, DBR and GI training were provided simultaneously. It is unclear if one MBI had a greater impact than another in improving scores. Future studies should seek to separate the participants into different groups, though randomized controlled trials for comparison, as in the meta-analysis by Spickerman et al. The study was 4 weeks in duration. A longer study is necessary to determine long-term results. This project attempted to address healthcare disparity in active duty female naval officers. The cost is limited to the initial provider's time and education, which may run up to $6,000 depending on the program, or free, as I'll discuss. I obtained my Yoga Alliance certified teacher education, which was $2,500. However, I did not pay that. The military offers programs to compensate providers for obtaining advanced education, rendering both technical and advanced degrees free of charge in exchange for return years of active duty service. The intervention may be disseminated by way of free virtual platforms such as Zoom. The cost to the patient in the civilian sector may range from $90 to $150 an hour. In the military, as free health care and time off to attend visits are benefits of employment to service members and families, they literally get paid while learning MBI. More importantly, the information taught through GI and DBR may freely be taught to others without the need for a mental health provider by the participant who's learned the subject material. The plan is to disseminate the research findings by abstract to AMSES Journal for the Society of Federal Health Professions. Furthermore, a poster presentation will be created to present at the 2024 California Association of Nurse Practitioners and the American Psychiatric Association conferences. Additionally, as social media is an effective means to cause a viral stirring in the masses, the abstract and flyer format will be created for distribution across platforms, including both military and civilian influenced areas. The hardest buy-in will be that at the pinnacles of military leadership at the Pentagon. While the APRN can present all the data, unless it is approved at the highest ranks, it will be waylaid. It is my hope that by providing the sound evidence and utilizing the assistance of APRNs at every echelon of the organization, this intervention may become a reality. The American Association of Colleges of Nursing outlined key elements required in the DNP curricula to ensure those earning the title are held to the highest expectations of practice. In DNP Essential 2, we must be able to synthesize and analyze practices based on the clinical and statistical significance found during review of literature. Review of literature supported the use of the paired samples t-test, as well as the usefulness of the intervention in decreasing anxiety. Through DNP Essential 4, the DNP stays at the forefront of technology to ensure they are using the best means to deliver care. This scholarly project helped to support previous literature on video teleconferencing and add to future military readiness regarding feasible technology and an application for its use. Essential 7 highlights the need to focus on prevention of populations. By teaching DBR and GI, it allowed patient determination at their time for their personal needs. By teaching techniques to immediately reduce and improve satisfaction with life prior to an event, not only prevention but enhancement of future and current mental health states may take place. Furthermore, once one understands the concept, they may teach it to others, educating the diaspora. I'd like to take a moment to voice my gratitude to my amazing husband Scott for his never ending support and my children Josh and Leia, who are my constant muse. Thank you, Dr. Cleary, for your patience and wisdom, and to Dr. Webb for his mentorship. But most of all, I'd like to thank the female naval officers who bravely stepped forward to participate in this project. I chose to do this project because in 2008, while I was an active duty pediatric charge nurse, I suffered from anxiety months after my daughter was born premature and my son was diagnosed with autism. I was misdiagnosed by psychiatry with bipolar disorder and medically retired. I spent 3 years proving my fitness for service and was brought back to active duty in 2011. When I returned, I vowed that I would become a psychiatric nurse practitioner to help others like me. I spent another 10 years in the Navy and retired in 2021, the Operational and Stress Control Readiness Officer of 1st Marine Division, 11th Marines. This CSP was more than a project. It was my dharma, and I am blessed to help people today because of it. The following references support this presentation. Thank you so much for your time and attention. I look forward to your questions and remarks.